I'm Ashish Beatty from Northern Chicago, and today I have the privilege of sharing some thoughts on Onlay versus Inlay healing for knee repair surgery. What does the data tell us, and how has this affected my practice around knee repair and reconstructive surgery? For this talk, I wanted to share a few important principles that I've learned that I think will help for us to inform how we make decisions in our practice and modern innovations in techniques and outcomes related to the knee fiber tack and suture lock implants. In terms of understanding healing, I think it's great to take a tour of the historic literature around onlay versus inlay healing, how the anatomy and footprints of the tendon and ligaments around the knee, in fact, should inform our decision making, and finally conclude with some cases and some technical approaches and outcomes. Let's start with biology. One of the most landmark studies that has been published in the area of tendon to bone healing was this great work done by Scott Rodeo and Steve Arnosky, where a dog model for ACL reconstruction was utilized to see how tendon healed in a socket in a tunnel. In this particular study, you can see these histologic analyses that showed the tendon and bone heal through this interposed fibrovascular scar tissue that matures over time with bone growing into the tendon. As this process occurs, we increase our biomechanical strength, so you can see this tendon pullout or load to failure that occurs at 28 weeks after healing compared to the time zero fixation. Well, how does this occur? When you look in their study, they see this narrowing of that fibrovascular scar tissue and organization into Sharpey-like fibers that are spot welds that occur within the tunnel. But the vast majority of the healing was the ingrowth of bone into that soft tissue. Well, do we have some parallel work to learn in Onlay? Well, one of the first landmark studies related to Onlay fixation was this great study by Pat St. Pierre and colleagues, where in a rotator cuff healing model, a goat model of infraspinatus repair, they compared healing to a cortical surface compared to one prepared with a cancellous trough. Again, the inherent concept here was that theoretically exposing cancellous bone and creating a trough in which to place the tendon might improve healing. But counterintuitively, the results actually showed no significant improvement in biomechanics or histology when that approach was utilized. Take a look at this data here from the study. You can see on the table, both at early and late time points, no significant differences in load to failure or stiffness between the trough and no trough constructs. Similarly, in terms of the histology, as shown in Scott Rodeo's study, it was this interposed fibrovascular scar tissue that gradually organized with fibrocartilage formation and eventually Sharpey-like fibers. Well, what brought some of these concepts together? This very important study done by Dr. Tan and Russ Warren and colleagues, taking advantage of an animal model for biceps tenodesis. For those of you who perform shoulder surgery, question of onlay versus inlay fixation has been a long-standing one for this procedure. In this study, using a rabbit model, they actually looked at both the biomechanics and histology of healing, comparing a tendon and a socket approach, which was the historical approach used for this procedure, compared to more modern onlay fixation using anchors. What did they find? Interestingly, no significant differences in biomechanics between the inlay and onlay approach. But what was humbling was to find that in the tunnel or socket approach, there was actually minimal bone formation within the socket or tunnel itself. In fact, only 5% of new bone formation on micro CT occurred in the socket, suggesting that even in the onlay group, most of the healing was the tendon to the surface on its way into the tunnel, suggesting that maybe onlay fixation is in some ways the way inlay fixation is occurring. This is the histology shown here, comparing the top group, which is the tunnel technique or socket technique, compared to the lower images showing the surface technique. You can see here both H&E and saffron and O staining. Saffron and O staining looks for metachromasia or fibrocartilage formation, which is a favorable sign at a healing enthesis. You can see this occurring in both groups, but predominantly occurring at the cortical surface, not in the tunnel. Has there been other work that has actually corroborated these findings? This study done by Richard Gelberman and colleagues in the hand surgery literature is highly informative. It actually indicates that tunnel healing was both histologically and biomechanically inferior to surface healing in a flexor tendon repair model. As you can see here on the bottom table and graph, biomechanics and ultimate load to failure at final time point inferior in the tunnel repair group. When you look at histology of healing, as shown here, both at early and late time points, compared to the surface versus tunnel group, greater metachromasia, greater organization of collagen, and more favorable alignment and healing histologically in the surface healing or Onlay group. This was also corroborated by some functional parameters. You can see here in terms of range of motion at the PIP and DIP joint, the surface groups had favorable range of motion, reduced cyclic displacement, and also in terms of new bone formation, better with a surface repair than a tunnel repair. This was very informative for me to see that even though we as surgeons often like to see a tendon placed into a socket or a tunnel, even our most historic literature doesn't necessarily suggest that that's best for biology. Well, why is that the case? Do we have anything we can learn from? This is a great study that actually tries to get at this question. In this particular study, they brought a hybrid concept together, and a tendon was wrapped in the periosteum, which is again critical for surface healing, and brought into an inlay or tunnel approach. They found in those cases in which the tendon was wrapped with periosteum, inlay healing and biomechanics was considerably better than without the periosteal wrap. This again suggests the benefit of onlay healing, and maybe some of that benefit relates to the presence of the periosteum, which may have favorable biology, vascularity, and cellularity to help at the healing interface. This has also been corroborated in a number of other great studies, again, leveraging work done in the shoulder. In this particular well-done animal study, rotator cuff healing was compared in a control group to one in which the surface was minimally prepared to expose the cortex, our onlay group, and then one in which the cortex was largely burred and removed to expose cancellous bone. These are what that looks like pictorially here. You can see this rat model for rotator cuff repair with a transosseous equivalent technique, again showing these three groups. What did we find? This concept that necessarily creating bleeding cancellous bone was not favorable, but in fact the opposite, less favorable, both in terms of the biomechanics of the construct, but also all the semi-quantitatively measured parameters of healing at the interface: cellularity, new bone formation, and organization of collagen tissue. Well, does this affect the knee? It certainly does. And I thought this was an interesting study looking at ACL reconstruction. This is a procedure where virtually all of us tend to make use of sockets and tunnels for repair and healing. What did we learn in this particular study? That what matters when you look at healing in that tendon socket interface are these spot welds of fibrocartilage and metachromasia formation. And it may not, in fact, be the socket that's important, but maximizing the fill of the tendon into that socket and minimizing the micromotion to allow for that new bone formation to occur. What was the principle here? Surface area and firm apposition of the tendon was the key, and this may be why onlay fixation is the key. Have we learned this in clinical practice? Again, great work done by our shoulder surgery colleagues that are leveraging that benchtop to the bedside. This is Pat Denard's great work here, where they compared the conventional older technique for biceps tenodesis using a socket and a screw at the top of the groove to a group where we look at with onlay fixation and a single anchor. You can see here, not only was the onlay group equivalent in healing, it actually had fewer complication rates, lower rates of re-rupture and Popeye deformity, and lower rates of requiring revision surgery. Hence, the concepts here, again, in systematic review and meta-analysis, looking at onlay and inlay fixation for biceps tenodesis. This great work done from Ortho Carolina by Dana Piasecki and colleagues show these forest plots of all of these well-executed studies, both by patient-reported outcomes, ASCS score, constant score, but also recurrent deformity and failure, working towards favoring onlay fixation. Well, if you think about that biology and that tour of the literature favoring surface area and onlay fixation and healing over socket healing, can we bring that together with our understanding of anatomy? This was a study I had the privilege of working on with Terrell Burris, where we revisited these concepts of anatomy specifically around the knee. I show these X-ray and fluoroscopic images here because these are the common points that we reference on X-rays to reproduce anatomy, for example, with ACL reconstruction. But what have we learned? We know that tendon healing and ligament anatomy is not a single point, it's a footprint. And that great work from Freddie Fu and colleagues, Bill Clancy and colleagues have taught us that footprint anatomy for ACL surgery in the anteromedial and posterolateral bundle, and the PCL in the anterolateral and posteromedial bundle. And we recognize that when we're restoring this anatomy, we want to fill those footprints and maximize that surface area of coverage and healing. Well, these principles not only apply for our cruciate and intra-articular ligament reconstruction, they also apply for our extra-articular anatomy as well. Take a look at the medial side of the knee. We often look at these fluoroscopic marks, as you can see here, and we teach our residents and fellows to identify Schottle's point for an MPFL reconstruction, or to identify the epicondyle and to reference it for the MCL origin. But we recognize the left picture is more normal anatomy. These are broad footprints where the ligaments and tendons insert to, and we want to recreate these footprints to maximize biology as well as restore anatomy. Those principles apply to the lateral side of the knee as well. We've learned so much about the use of fluoroscopy from Rob Laprade and others to recreate the posterolateral corner. We've learned about these landmarks for the ALL procedure, but we recognize once again, these are footprints that need to be recreated, not singular points. And using the right technique and technology to do that is critical. This is exactly where we translate that again from the benchtop to the bedside. These are intraoperative fluoroscopic images. You can see on the right side on the patella where we may want to recreate the MPFL. On the femoral side, the posterior cortical line and Blumensatz's line that are utilized to identify Schottle's point. But once again, in the OR, we want to recreate the footprint of the MPFL, both on the patellar and femoral side. And this is where we can now evolve and bring biology and anatomy together to technology and innovation. Let's bring this right to clinical practice. This is a patient of mine, a 20-year-old offensive lineman who's had multiple history of patellar instability. These were treated conservatively with rehabilitation and bracing, but it's now becoming recurrent and a nuisance to a level where he is unable to continue to compete and wants to play an additional couple of seasons during his collegiate career. What do we see here? No special findings, the typical findings of a patient with patellar instability. Findings of patella alta, some mild trochlear dysplasia, even a little bit of mild malrotation. The Merchant view, again, identifying these findings and even this small osseous avulsion fragment consistent with chronic patellar instability. What's critical, though, is recognition on the MRI of the soft tissue disruption. And this is, again, what has been enlightening for me. The recognition that the pathology for this patient is stretch injury to the MPFL and medial retinaculum, which is a broad footprint on the patellar and femoral side. It's recognition of the associated osseous bone bruises on the medial patellar facet and the lateral trochlea that have continued to occur to also damage chondral structures and intra-articular anatomy as well. When you bring this to the coronal view, you can appreciate this even more so, where you see the broad superior half of the patella affected by the MPFL avulsion type injury, and the broad insertion that's confluent with the medial retinaculum at the level of the femoral epicondyle. Why is this important? Because my historical approach to this patient would have been a docking fixation. I would drill a socket on the patella with 2 exit drill holes. I would drill a socket on the femur. That would not reproduce the anatomy. The drill hole and socket would largely violate the footprint to allow for those surface area and spot welds for healing. And even more concerning was the risk of a patella fracture, sometimes with a 6, 7, or 8 millimeter socket prepared at that supromedial patella. It took just a few of those complications in my practice to realize these critical principles. If I could identify the implant and technique that would minimally violate the footprint, recreate anatomy with great biomechanical fixation, and be reproducible for every patient in my practice, that would be the evolution for my technique. And this allows me to share a bit about why the knee fiber tech has impacted my knee reconstructive and repair practice in so many ways. The knee fiber tech anchor does exactly all of those things and checks the boxes in all of those areas. It's onlay fixation with minimal cortical preparation. It's small 2.6 millimeter anchors that minimally violate the footprint with different configurations to allow for all of your repair and reconstructive needs. some with pre-converted loops to simply bring the tendon structure in or ligament repair in and allow secure fixation to the footprint, but other situations where you may want to additionally imbricate and sew. In addition, these allow joint line fixation intra-articularly and extra-articularly for all of your different repair needs. Well, what does that look like in this patient? Previously in the past, the patella would be the socket with exit drill holes all the way across the patella with the stress risers and challenges I shared. You can see here, you can now place those anchors in the superior and inferior aspect of the patellar footprint and simply bring in your tendon and directly oppose it, maximally covering the full area of the patellar footprint. Similarly, the left side of the screen here shows my old approach to femoral fixation. This was a socket and a screw, greater exposure, larger dissection, and again, not recreating anatomy and surface area for healing. Today, this is Onlay fixation with a hybrid fiber tack anchor that allows for surface area for healing, Onlay biology, which we've shared is favorable, and secure biomechanical fixation with minimal disruption of the anatomy. This is shown here in a video that I recreated here using a cadaver. None of this has been sped up. It is truly this simple and easy to perform. Here we mark the footprint on the patellar side. You can see minimal roughing and preparation of the cortex. In this particular case, 2 hybrid anchors are placed superiorly and inferiorly in the patellar footprint. As these are prepared and secured, we move to the femoral side. Here we simply expose Schottle's point, which has been identified fluoroscopically. But what is so convenient here is we can place the drill bit and actually leave this drill bit in place, slide the knee fiber tack guide over the drill, which then allows you to immediately deliver the anchor as a single step. We now, by minimal violation of anatomy, can work between the 2 incisions, between layer 1 and layer 2 of the knee, and are now fully prepared to deliver our graft. In this particular case, whether autograft or allograft tissue, we bring our graft onto the patellar side and actually deliver the mid portion directly against the patellar footprint. Here, the hybrid anchors have been utilized, recreating the footprint with secure fixation and keeping these additional swedge stitches for later for repair of the retinaculum and even VMO advancement if desired. This to me is also a significant transformation shown here. Here we mark the location of the graft, but we don't have to re-prepare our graft as we had to in the past to match the length and fixation in a blind socket on the femoral side. Using the hybrid and anchors here, or in this case, the 2 pre-converted anchors, we can simply secure the graft to the footprint for secure onlay cortical fixation, getting this right reproducibly every time. And all of this efficiently with minimal disruption of anatomy. This has been a transformation, not just for the MPFL, but for any procedure in which I'm looking to achieve onlay fixation with minimal dissection, reproducibly, and taking advantage of the principles that we shared of biology. Let's take a look at a very common procedure that is occurring more and more in knee repair and knee reconstructive surgery. Many of you will recognize this radiographic sagittal X-ray or lateral X-ray. These are the landmarks published by Halito and Camacho and others that we utilize to identify the origin and insertion of the ALL. But we recognize again that while we identify these points, what we look to create are these broad footprints to maximize biology and healing. What does this look like in principle? If we do an LET procedure as shown here, we end up with the IT band graft shown on the left, tunneled deep to the LCL. This video, done elegantly by Walt Lowe, shows how quickly and efficiently this procedure has evolved with this technology of the knee fiber tack anchor. In this video, he demonstrates harvesting the IT band graft. In the past, if a socket was utilized on the femoral side, it carried some risks. The risk of injuring your ACL graft and fixation, the risk of a large socket, the risk of matching the length of the harvested IT band to very much align with the depth of the socket to avoid a graft tunnel mismatch and loss of tension or failure. Here you can see using this hybrid anchor, we can simply bring the graft and secure fixation at 30 degrees of flexion and neutral rotation, achieving an excellent reproducible result for our LET procedure every time with cortical healing and no risk to our ACL graft. Does this translate to other areas of the knee? Well, it does with modern innovation and technology. Let's take an example of the meniscus. For me, in surgical practice, no area of knee surgery has seen greater change and transformation than meniscus surgery. There's a huge recognition of the meniscus root and root variant tear patterns that for years probably saw me, even though I didn't appreciate them. Even in subsequent years, when we appreciated these tears, we lacked the technology and approach to reproducibly repair them in a reliable fashion that allowed for healing. Well, that's changed. We now recognize that the anatomy for the anterior and posterior root is important. These are footprints that we recreated with meniscus transplant surgery that we now recognize we need to recreate with meniscus root repair surgery. This is the suture lock implant, which is a hybrid developed technology that leverages all the benefits of the knee fiber tack and allows for joint line fixation, the only implant of its kind for root repair surgery. The image here shows the root repair of the past. You can see we would try to pass sutures through the root, bring it through a long tunnel, and achieve suspensory fixation on the tibial side, either over drill holes or over a button. None of us felt good about that suspensory fixation, but it was the best option we had given the challenge of joint line fixation and approaching that anatomy deep in the posterior aspect of the knee. The suture lock implant allows for retrograde delivery, which then allows for this knotless, tensionable, and retensionable construct to achieve joint line fixation. This is how that's done using the root repair guide and minimal cortical preparation of the root footprint. We're able to drill a 2.4 millimeter cannulated drill into the center of that footprint, preserving the bone and surface for healing with the root and the root variant tear. This is how that looks in stepwise format: preparation of the footprint, followed by delivery of the pin, shuttling the suture lock implant and deploying it at the joint line, followed by meniscoscorpion delivery of the repair stitches and converting of those knotless constructs to achieve excellent biomechanical fixation of root and root variant tears. This is a video showing those principles in practice and how elegant this surgery has become with this innovation. Here, the surface has been minimally prepared. You can see this 2.4 millimeter pin minimally violates that footprint to preserve that bone and surface area for healing. The suture lock implant is then retrograde delivered just inferior to the joint line and deployed. This then allows now for routine suture passage and fixation. What's nice is it's double loaded, and so this can allow for a variety of different repair constructs. It can be simple or horizontal mattress sutures, or even modified Mason-Allen constructs based on the directionality of passage to minimize the risk of failure at the suture-meniscus interface. This maximizes the biomechanics of the construct, the biology of the construct, and the interface between the footprint and the meniscus for healing. Well, does any of that matter? Can I show any data that would suggest that matters? Again, leveraged from our colleagues in shoulder surgery, we've studied this in the greater tuberosity. You can see here when you look at the greater tuberosity footprint, we violate about 40% of that footprint with conventional hard body anchors. Does that make a difference if we minimize that violation? It does. This is the native architecture of an enthesis, this organized construct from tendon to unmineralized fibrocartilage to mineralized fibrocartilage to bone. We need to maximize that surface area to allow for this fibrovascular scar formation, which subsequently matures into those Sharpey-like fibers. If you look at fiber tack anchors, in this case, the 2.6 millimeter anchors, same size for the knee and the shoulder, this violates less than half of those 5.5 millimeter hard body anchors, 17.7% versus almost 40%. Does that make a difference? Well, certainly this study from Joe Lampla and Pat Denard gives us some thought to consider this approach. When you look at the conventional speed bridge, the biomechanics of that fixation construct are not compromised at all by using these all suture anchors. But what is improved upon is the contact force between the tendon and the footprint. That improved contact force combined with that greater than 20% increased surface area almost certainly increases the spot welds for healing. So in summary, I would leave you with these thoughts and hopefully share my learnings and insights from the literature and practice with all of you. When you're considering onlay and inlay fixation, the biology today would suggest for your knee repair and reconstructive surgery, surface healing or onlay healing may actually be favorable to socket and tunnel healing. We're learning more about why this is, but it appears that the periosteum is a critical component to that healing. Furthermore, cortical healing is sufficient, and a minimal preparation of that footprint is actually favorable over removing the cortical bone and exposing cancellous bone. This is counterintuitive to our conventional approach of socket healing and socket preparation, which was probably informed more by technical reasons than biologic ones. Given that favorable biology with cortical healing, we know that maximizing contact force and contact area is critical to maximize the opportunity for those spot welds. And we should use the technique and implants that allow us to optimize those biomechanical principles and optimize biology. For that reason, the transformation in my practice has been from inlay to onlay fixation using the knee fiber tack and suture lock anchors for meniscus repair and ligament reconstructive and repair surgery. I aim to restore the footprint, maximize area for healing with no compromise in biomechanical fixation. These knotless devices also allow for tensioning and retensioning, which for me is an incremental improvement over the past. Thanks for your time and attention today.